Hey guys, welcome to part 8. So in part 7 I promised we'd go through Neuroleptic Malignant Syndrome and Serotonin Syndrome, the differences and stuff like that. And what these two conditions are is they're really drug-induced hyperthermic conditions, hyperthermia, okay? And I'm going to throw into the mix, just because I think it's relevant, malignant hyperthermia and anticholinergic toxicity, because all of these are drug-induced hyperthermias. But first, let's start with our two big boys, NMS and serotonin syndrome. So serotonin syndrome, you're going to think of SSRIs immediately off the bat. It's in the name. But what the test is going to throw in, just to try to throw you off, is an MAOI, a TCA, ecstasy or MDMA, and triptans, because they know that serotonin syndrome and SSRIs is obvious. But other serotonergic drugs like MAOIs, TCAs, MDMA, and triptans, those can also cause serotonin syndrome. Now, the onset of serotonin syndrome versus NMS from the onset of the time the drug was taken is very different. So serotonin syndrome is more acute. It's going to happen within 24 hours. NMS can take days to weeks. Okay, so that's one of the key differentiators. So remember, serotonin syndrome is focused on the 5-HT receptors, and neuroleptic malignant is focused on the D2 receptors. Particularly, we have D2 antagonists acting on those receptors, causing these kinds of symptoms we see in NMS. So what are some examples? So haloperidol, right? Flufenazine is another one. Clozapine, right? The antipsychotics. All right, so if we want to really compare these, we want to compare different clinical symptoms, because usually the test won't give you, oh, this person was on an SSRI or this person was on an antipsychotic. That would be too easy. So they're going to give you, oh, this person was on some kind of medication at home for a psychiatric condition, and now they're coming in with this hyperthermic rigidity potentially, and you have to figure out which one is it. So in serotonin syndrome, you're going to have hyperthermia, hypertension, okay, and the bowel side effects here are part of the autonomic condition of serotonin syndrome, and they're key to look out for. So they're more likely to throw a diarrhea, an increased bowel sounds, a diaphoresis in serotonin syndrome rather than NMS. Okay, so autonomic dysfunction is a little bit more common in serotonin syndrome, but you can also see it in NMS. They'll emphasize it in a serotonin syndrome question. Next, we have changes in things like neuromuscular activity. Now, how do you quantify this and what's the difference? So serotonin syndrome is going to have hyperreflexia, while NMS will have hyporeflexia. So that is one of the key differences. Hyper versus hypo, they're direct opposites. If you get this distinction right, it can save you a point on the test. You don't even have to read the rest of the question to be able to differentiate, okay? So serotonin, hyper, NMS, hyporeflexia, okay? And then in serotonin syndrome, you'll see things like clonus, or that repetitive movement, hypertonia, and in NMS, you'll see something like a lead pipe rigidity. It's very severe. They're not moving out of a specific pose, which they're fixed in, okay? But the main key take-home point is the hyper versus hyporeflexia, okay? All right. In the treatment for these two conditions, okay? The treatment is going to be usually discontinue the drug they were on, so that's the first step in both. And then serotonin syndrome, they like to do benzodiazepines as second line and cyproheptadine as second line. While in NMS, you'll have bromocriptine, which is a dopamine agonist, as well as dantrolene as your second line. So just remember, for both, you're going to want to discontinue the drug. Now, how do we differentiate? Let's just go through this one more time, because I think it's relevant. Serotonin syndrome will have more autonomic symptoms. Look out for the diarrhea, look out for the increased bowel sounds. And then serotonin syndrome has hyperreflexia. NMS has hyporeflexia, and they're also more likely to mention something like a lead pipe, very severe rigidity with NMS. All right, so in both, discontinue the drug, serotonin syndrome, benzodiazepines, and NMS, bromocriptine, if you had to remember one drug for each. Okay, now let's add on to this with a little bit of, with some other conditions that are similar mimics, okay? First is malignant hyperthermia. This happens with volatile anesthetics. Your halothane, for example, is a good one here, and succinylcholine also is a good one to remember for malignant hyperthermia. This is also very acute. It happens within minutes and latest within 24 hours. Unlike NMS, remember, days to weeks, serotonin syndrome is also within 24 hours. So you'll have hyperthermia, tachypnea, you can see something like a libido reticularis with flushing and cyanosis. This is another key finding. Libido reticularis is, what that means is it's a blue, kind of reddish blue discoloration of the skin in a net-like pattern. And this is caused by blood vessels spasming. It'll be characteristic. You'll see kind of characteristic lines on the person. And it's very obvious if they show you a picture. You'll see a straight outline of a blood vessel superficially from it spasming and rising to the surface. Okay, so common features besides hyperthermia, tachypnea, mottled skin or libido reticularis. You'll see things like muscular rigidity. So that is, all of these have muscular rigidity. That's kind of how you get the hyperthermia, because your muscles are contracting so hard, your energy is being burnt up and your temperature is going up, okay? And the masseter muscle here will also be very contracted. Don't put your hand in these people's mouths. They could bite it off, okay? All right, and one of the things they really like to throw in here, because it's an anesthesia kind of question, is end tidal CO2. End tidal CO2, which is kind of a measure of your organ perfusion of oxygen, right? How much CO2 you're able to create is how much you can metabolize oxidatively, is going to be increased, right? You're not breathing as well. Your tissues are going to be pulling all that oxygen out of the vasculature into them, and they're going to be producing a lot of CO2, right? So CO2, end tidal CO2 is going to go shooting up in this kind of condition. End tidal CO2 is high in malignant hyperthermia. I think it's a great point to remember for a test. And dantrolene, just like in NMS, is our therapy here. Now remember, dantrolene is a ryanodine receptor blocker, so it's going to stop calcium from moving around and causing more contraction. All right, so anticholinergic toxicity is going to be our last one. Remember that when you block cholinergics, you're going to have sympathetic overdrive, and that's going to cause someone who's warm, dry, with flushed skin, they'll have decreased bowel sounds. So that is in strict contrast to our serotonin syndrome, where you have increased bowel sounds. They'll have urinary retention. So autonomic dysfunction is opposite if you're considering anticholinergic toxicity versus a serotonin syndrome. In serotonin syndrome, your autonomic nervous system is going towards, a diarrhea, a diaphoresis, while in anticholinergic toxicity, your bowel sounds are decreased, you're retaining urine, you're warm and dry, you're not sweating. That's an opposite there. Okay, so watch out for that, and reflexes are going to be normal. There's not going to be any hyperreflexia from serotonin syndrome. There's not going to be any hyporeflexia from NMS, okay? So that's a key differentiator also. And how do you treat anticholinergic toxicity? Well, you're going to have an anticholinesterase inhibitor like physostigmine. That's the drug of choice there, okay? So I hope this has been a little bit of an extended review of drug-induced hyperthermias, and it's gone through each of the points, and so we all kind of understand them pretty thoroughly. Okay, so the next thing I want to tackle in today's podcast is tick-borne diseases. Now, ticks have a nice host of diseases that they like to create or host in their bodies and then transmit to us. And the boards like to test them because they love to test rare stuff and trip us up. So the first one, and I think a really important one to know, is Rocky Mountain Spotted Fever. Actually, let's do a quick overview, and then let's jump into each one more specifically. Okay, so our main tick disorder, the most common one probably that appears on tests and even on wards, is going to be Lyme disease. Now, Lyme disease is caused by Borrelia burgdorferi. That's the pathogen, and you're going to find it in the upper Midwest, the Northeast. Those are the two key areas of the United States where Lyme disease hangs out. And what kind of clinical features will you see with classic Lyme, right? You're going to have fever, flu-like symptoms, stuff that's pretty non-specific. And the rash is called erythema migrans. You can think of it as a migrating bullseye rash where the center is clear and the kind of red circle is expanding. All right, and that's early Lyme disease. So that migrating bullseye rash, the fever and non-specific symptoms. Now, once you have disseminated Lyme, that's when you get into territory of arthralgias, nerve palsies, meningitis, things like that, things that are affecting your bones, your nerves, even your heart. Heart blocks are a disseminated Lyme symptom. And then in very late Lyme disease, you'll have the chronic arthritis from continuous arthralgias, right? The joints have been chronically inflamed, which create an arthritis-like picture, right? You'll also have things like it's called late neuroborreliosis. So this is a progressive encephalomyelitis. You'll see chronic inflammation of the kind of meninges, and it's going to be aseptic. If you do an LP, you're not going to find organisms. This is a progressive encephalomyelitis, and it also can present with peripheral neuropathy if you let it go on for long enough. All right, so that's our big guy, Lyme disease. How do we test for it? Well, we're going to have the initial test be our ELISA test, and then we're going to confirm with a Western blot. So it mimics sort of an HIV picture. If you want to do an ELISA, then a Western blot. That's pretty common HIV fodder. And then treatment. So the treatment is in two groups. If you have neurological symptoms or if you don't. If you don't have neurological symptoms, then you're going to go straight for doxycycline, amoxicillin, or cefuroxime. Those are our three main Lyme drugs: doxy, amoxy, cefuroxy. All right. And then if you do have neurological manifestations, if you're going towards a disseminated Lyme or a late Lyme picture, you're going to use IV ceftriaxone. So those, it's very key to imprint into your brains and into my brain that the difference between early and late Lyme is not just the presentation. You get more neurological, more heart blocky as you go down the rabbit hole. You also have to switch your antibiotic, right, to IV ceftriaxone. Okay, next one we're going to cover is going to be Rocky Mountain Spotted Fever. Now this one is lethal. Just remember that if you don't treat Rocky Mountain Spotted Fever, that person is going to die. So that's why they like to test it, because it's high yield. If you miss it, you can cause big problems for the person who got it. So this is a Midwestern bug. Rickettsia rickettsii is the pathogen. Okay, and what you're going to get is fever, flu. So again, we're going non-specific. A blanching maculopapular rash that starts at the wrists and ankles and moves centrally. If you remember the sketch for this, there's a mountain climber and the rash is moving from their hands towards their body where they're touching the wall. So it's a centrally moving rash, and it rapidly clinically deteriorates to a shock and multi-organ dysfunction if you don't catch it in time. All right. So how do you detect it? It's going to be a PCR test, and you're going to look for the rickettsia antigen. You can also stain for it. You can also, if you want to, so there's the PCR test or immunohistochemistry for the our rickettsia antigen. Okay. The other thing that you need to know about this Rocky Mountain spotted fever is how do you treat it. And doxy is a favorite drug for treating these kind of tick-borne or animal-borne illnesses. So if you had to guess on any kind of test and you think, oh, this is a forest-borne illness, something that comes from animals, doxy would be right, and I think at least 50% of cases. Okay, so doxycycline is the mainstay of treatment for Rocky Mountain spotted fever. Bubysiosis, it's caused by Babesia, and this is again in the Midwest. You're going to see it especially in Minnesota and Wisconsin. Those are the two states they love for Bubysiosis. And Bubysiosis is interesting because it causes hemolytic anemia. So this bug goes into the red blood cells and pops them. Okay. Hemolytic anemia is also associated with splenomegaly and hepatomegaly, but these are going to be mild, so they won't always show up. And there's typically no rash with babesiosis. So unlike Lyme, unlike Rocky Mountain spotted fever, you don't get a classic rash. You'll see that for these kind of blood-borne or these pathogens that infect the blood, they're going to have no rash. Erlechiosis is another example that we'll talk about in just a second. So, in babesiosis, you're going to be anemic, right? Your RBCs are going to be down, your hematocrit's going to be low, your reticulocyte's going to go up, and that's because now you're trying to compensate. Your bone is trying to make more red blood cells. You're also going to have things like Maltese crosses on microscopy. The Maltese cross is a classic sign of babesia. It looks like three little ovals that form a cross on the immunohistochemistry stain. And babesia DNA can also be found on PCR if you're doing a PCR analysis. Now, there's a differentiation in treatment for babesia as well. There's mild and there's severe. So for mild disease, atovaquone and azithro are your mainstay of drugs. Atovaquone, remember, atovaquone proguanil is an anti-malarial drug. It's used for chloroquine-resistant falciparum, and it's also used for malaria prophylaxis. And then azithromycin is our classic macrolide. So if you remember the sketch for this, it's the atovaquone and the macrolides are the macros. So there's a queen and some crows in the picture. That's how you remember atovaquone and azithromycin. For severe disease, you want to use two separate drugs. So you'd want to use quinine and Clinda. Now, quinine, if you remember from the from pharmacology review, is also another malarial drug, and basically I don't remember the exact mechanism, but it has a lot of side effects like nausea, dizziness, headaches. It's a pretty intense malarial drug. So just to keep in your brain that the difference in babesia treatment is based on the severity, and I'm sure there's some hemoglobin cutoff which we might review in the future, or like how low do your CBCs have to be before you're going to switch from atovaquone to quinine, how low azithro to Clinda. All right, so Erlechiosis is our next one. There's different Ehrlichia bugs. There's Ehrlichia caffenensis, and Ewigny, and Muris. So Ehrlichia comes in all kinds of flavors, but the main thing is that it's found in the Rocky Mountains. So if they want to trick you, they'll put this boy has been climbing or this girl has been climbing in the Rocky Mountains, and they'll want you to pick Rocky Mountain spotted fever because it's in the name. But remember, the real bug of the Rocky Mountains is Ehrlichia. And you can have the fever, the flu-like symptoms. All of these have that. Every single one of these bugs has fever and flu-like symptoms. So just remember, non-specific symptoms are non-specific for a reason. There's no rash, okay? You'll do a peripheral. There's also potentially no anemia, right? So you're going to have a very difficult time finding Erlechiosis. So when you do, for example, a peripheral blood smear, you won't see the Maltese cross of Babesia. You'll see kind of clustered inclusion bodies. Sometimes it's called a mulberry presentation. Just look up a picture on Google Images. And the main treatment here for Erlechiosis is doxycycline. Erlechiosis is not very well tested because there's no exactly key fact to look out for besides that it's found in the Rocky Mountains. But we'll do a quick review of it anyway because I think it's important. Okay. Anaplasma, tularemia, Colorado tick fever, tick paralysis. I think we should go through those. And the star tick association is also important. So those are some more, I think, tick-borne illnesses that we should cover. So anaplasmosis. This is an upper Midwest bug. There's fever, flu-like symptoms, just like every single other one of these bugs. I'm going to beat that in your heads, I think, by the end of this quick podcast review. There's no rash again. There's leukopenia, thrombocytopenia, and mild anemia. So if you're looking for a pancytopenic bug, a bug that affects multiple cell lines, you found it. It's going to be anaplasma. And in granulocytes is where you're really going to see it on the smear, right? It's going to be your neutrophils. It's going to be your basophils, your eosinophils. Your granulocytes are going to have the morula inside. So don't look for it in the red blood cells because you're not going to find it there. You're going to see it in the granulocytes. All right, and treatment, of course, if you had to guess, doxycycline. Tularemia. Tularemia is classically associated with rabbits, and it's also associated with all the states except for Hawaii. Weird fun fact, but I've seen it on a test before. It gives you a bug, it tells you that it's in Hawaii, it tries to make you think it's tularemia. Not found there, okay? So don't look for it there. All right, you're going to have a skin ulcer with tularemia. That's the site of infection. And also tender lymph nodes in that area. So skin ulcer, tender lymph nodes, classic for tularemia. You can culture tularemia in agar, so that's the main way of diagnosing it. And here we actually have doxycycline, as you would expect, and you can also use streptomycin and gentamicin. So if you really wanted to, you could throw aminoglycosides at this bug as well. Next, we're going to talk about southern tick rash illness, or southern tick associated rash illness, which is also known as STARI. This is one of the ones that's more niche, more unique. It also has an erythema migrans-like lesion. It's not associated with any dissemination or nerve palsies like Lyme is. So you're going to have just the erythema migrans kind of picture and then nothing later. So make sure you have this on your differential for Lyme. There's no confirmatory test for this. It's a diagnosis of exclusion once you've ruled out Lyme. And you guessed it, you can treat it with a doxy. And then tick paralysis. Tick paralysis is caused by tick neurotoxin, and after an initial tick bite, you can have this tick paralysis up to a week later, and it starts with weakness in the lower extremities, and it ascends. It's like kind of an ascending weakness. It ascends to total body flaccid paralysis, and you kind of diagnose it by finding a tick. If you find the tick, you're like, oh, there we go. There's where our potential paralysis comes from. Now, this is an obvious key differential for Guillain-Barré, where you also have the ascending paralysis. So you remove the tick, you do supportive therapy, and boom, your tick paralysis is solved. Quick review. Let's go through some of the key ones we've talked about, and then we'll call it a day for this topic. So, Rocky Mountain spotted fever, Rickettsia rickettsii. It's found in the American dog tick, the wood tick, the brown dog tick. This is a dog tick disease. If you have a dog owner, this is one to really consider. Rocky Mountain spotted fever. It'll incubate for 4 to 10 days, so it's going to take some time for this disease to start up in a person. But once it does, you have to catch it quick, because remember, untreated shock fatal. It's the centrally spreading rash from the arms to the trunk, from the soles of the feet to the trunk, right? And there's rapid clinical deterioration afterwards. You can get meningitis, focal neurological deficits, gastrointestinal symptoms are common. These people come in with abdominal pain, right? When you order labs for this kind of disease, you will have a normal WBC count, right? A normal WBC count. Watch out for that, because they'll try to trick you, okay? PCR is the main diagnostic test here. You can also do immunohistochemistry, but I think most places do PCR for this kind of thing. And treatment is doxycycline. Remember doxycycline for all of these tick-borne diseases, because you need to treat it as soon as you suspect it. Don't wait for the diagnosis. If you see the centrally spreading rash, throw that treatment on there, because it's very critical. Okay? All right, and you need to treat within 5 days of getting it, because if not, that's a poor outcome for most patients. Bubysiosis. So Babesia is spread by the Ixodes tick, right? And this is a Midwestern disease. You're going to have fever, you're going to have hemolytic anemia, dark urine, jaundice. They might not tell you hemolytic anemia. They'll be like, oh, this person from the Midwest comes, or like Minnesota, comes to your clinic with a jaundice-like picture, some mild hepatomegaly. They're going to have no rash. They could even be asplenic, because that increases your risk, right? Asplenia is an immunocompromised condition. They're going to be anemic with a high retic count, and then on the peripheral smear, you're going to see these Maltese crosses. Boom, there you go. That's babesiosis. And the treatment is atovaquone proguanil plus azithro and quinine plus clinda if severe. Okay, this is one that's not a doxy-dependent guy. Remember, doxycycline is pretty much right for everything except for babesiosis. You just have to remember the babesiosis sketch with I think they're babesiosis witches or something. And they have the queen, atovaquone, with the azithro crows. And the quinine plus clinda is the second line for severe infection. Okay, Erlechiosis. Erlechia capensis. Why do they make that so hard to pronounce? Anyway, that's another Ixodes tick-borne disease. You have anemia, thrombocytopenia, leukopenia. If you have a pancytopenia and you have a tick-borne illness, Erlechia is your bet right there. All right, so that's one of the key points to remember. A pancytopenia with a tick-borne illness, that's Erlechia. Okay, and treatment is doxy. So you'll see kind of like those. They like to test this one with histopathology as well. You'll see those clusters inside of granulocytes, so watch out for that. That's a common way they like to test this one as well. Anaplasmosis. So this is, again, an Ixodes tick, Ixodes scapularis, Ixodes pacificus. Whichever Ixodes, Bixodes, it's hard to keep them all straight and narrow, but it's an Ixodes tick. You have the classic fever and flu-like symptoms of all of the tick-borne diseases. It's going to be someone who grew up on the West Coast, no rash, mild anemia, thrombocytopenia, leukopenia. This is another one that can show up with a little bit of pancytopenia. So Erlechiosis, right? Anaplasmosis, and this is why I think they don't really go after these two as much on tests, because they can be difficult to separate apart if you have just blood work, for example, because they don't like to give you, oh, this person's anaplasma DNA was positive. Then what are you going to do? They're just going to test treatment, and they know everybody goes for doxy, so that would be way too easy. So anaplasmosis is going to show you morulae within granulocytes on the peripheral smear, and with Ehrlichia, let's contrast that with Ehrlichia, you're going to see morulae within granulocytes as well. So the hardest thing to differentiate really is Ehrlichia and Anaplasma. Those are always very difficult to have a good differentiator. You really need infectious disease to come on there because they're so close in terms of symptomatology. All right, disregard what I said earlier about Ehrlichia being the only one with pancytopenia. Anaplasma can have that too. Tularemia, okay, not in Hawaii, right? It's found in ticks and deer flies. It's associated with rabbit farmers, okay? And you're gonna have a sore with regional lymphadenopathy. It's just how it is. All right, and you can have things like increased transaminase, increased CPK, positive cultures with yeast agar. So this is a cultured organism. You have, for these patients, you want to do chest x-ray and CT if you suspect pulmonary involvement, because this can have pulmonary infiltrates, hilar infiltrates, pleural effusions. This is one of those that has pulmonary signs on its manifestation, okay? And you can throw doxy at this again, but you can also throw aminoglycosides on it. Gentamicin, streptomycin. Tularemia is a great disease to throw aminoglycosides on, and it's a reportable disease. Remember, you have to report this to the CDC if you have an outbreak, because it spreads quickly. Okay, Stari, which is Southern Tick-Associated Rash Illness. It's a Lyme differentiator with no neurologic signs. Just remember that. And tick paralysis. You remove the tick. You do local supportive therapy, and you're fine from there. All right, so I think we've gone through all of the tick-borne diseases that are really the most relevant. I'm sure we could have done some more. For example, maybe Colorado tick fever or those kind of diseases. But I think those are in general not super tested. And if it pops up, if I see it pop up, I'll revisit the topic and we can go over it again. Okay, so speaking of ticks and bugs, I think another thing that they love to throw on tests is diarrhea, because it's such a common symptom. So common, and they love to test, which bugs cause watery diarrhea, which bugs cause bloody diarrhea, what are the extra gastrointestinal manifestations of these bugs, which ones cause like joint pain and things like that, which ones have spread to the liver and cause systemic damage. Okay, so let's go through the differential on a watery diarrhea versus a bloody diarrhea in patients. Okay, watery diarrhea. Watery diarrhea, your main culprit here is definitely going to have to be E. coli. Okay, Enterotoxogenic E. coli. This is traveler's diarrhea. It has two toxins, heat labile and heat stable, that cause the irritation and then cause your watery diarrhea. C. diff is another one. It also has two toxins, toxin A and toxin B. Toxin A is an enterotoxin. Toxin B is a cytotoxin. That's going back to a little bit of step 1 knowledge. And of course, it creates your pseudomembranous colitis. And very rarely, in rare conditions, it's going to cause bloody diarrhea. It's the C. diff diarrhea is most likely going to be watery. So don't get confused and think, oh, because C. diff is so severe and a lot of patients, I'm going to think it's bloody. It's a watery diarrhea. Clostridium perfringens. Remember, private fringens from the sketches. This is a bug with a heat labile toxin similar to E. coli, and it also has something called an alpha toxin, right? Alpha toxin is also involved in things like hemolysis, right? So it's going to produce that double zone of hemolysis on blood agar if you culture it. It's also involved in the gas gangrene formation of Clostridium perfringens when it presents in the skin. Clostridium perfringens, watery diarrhea, okay, and gas gangrene. Most of the time they're going to know that you know the gas gangrene association, so they might go for the watery diarrhea angle. Fibril cholera. So cholera is one of those curved comma-shaped organisms that produces an enterotoxin causing rice water diarrhea, right? You'll get it from either infected water sources. Uncooked seafood like raw shellfish is a great cholera vector, and they will go for that as an answer choice because they know that you know that infected water is a common vector. So uncooked seafood can cause cholera because seafood lives in water, right? So it's just one step further in logic processing that they like to throw in. Okay. Other things that can cause watery diarrhea. We've gone through the bugs. Let's go through the viruses. So the bacteria, now the viruses. Norovirus, rotavirus, adenovirus. Great viruses for watery diarrhea. Norovirus is airborne. Okay. It's the most common cause of diarrhea. Rotavirus is fecal-oral. And you want to know that you prevent this one with the vaccine in children. This is a live vaccine in children. You don't give it to children under 1 year old. Actually, I think this is the only one you give to children who are under 1 year old, and it can cause intussusception. I think also you want to avoid this one in immunocompromised children, but you guys can check me in the description box below. And then adenovirus. Adenovirus is transmitted also fecal-oral. It's going to cause multiple things, not just watery diarrhea. You know, it's one of those double-stranded DNA viruses. It's common in daycares. You're going to have the pharyngitis, the conjunctivitis, the pneumonia, the hemorrhagic cystitis, among other symptoms, not just watery diarrhea. But you have to put it there as a watery diarrhea cause, right? So watery diarrhea plus gastroenteritis, you want to suspect one of these viruses. Protozoa, right? Protozoa are also diarrhea causers. The main one to remember is probably Giardia, right? Infected lake water, right? People that are hikers, campers, Giardia is on your differential. Cryptosporidia. This is one of those, Cryptosporidium parvum is one of those intracellular parasites that causes self-limiting diarrhea in people who are immunocompromised, immunocompetent, and really terrible diarrhea in the immunocompromised, right? Very severe gastroenteritis in immunocompromised people. This is fecal oral, most most of these, and the immunocompromised population is the one you really want to watch out for Cryptosporidia. Right. Now, we've covered our watery diarrhea sources. The ones that I think are people easily forget are C. diff. You're like, is that watery? Is that bloody? That's watery, okay? That's Clostridium perfringens. That's watery. I know the gas gangrene looks gnarly and intense, but it causes diarrhea that is watery, okay? Remember that adenovirus, the diarrhea is watery, even though you can get the hemorrhagic cystitis. The blood is from the other end, not from the bowel, okay? And then Cryptosporidia, the stool is watery. I know it's our first instinct to go for bloody stool because we think everything on a test is severe, but we have to take a step back and remember watery diarrhea causes. Now let's go into bloody. So we talked about ETEC. Now there's other kinds of E. coli that cause bloody diarrhea. These are enteroinvasive and enterohemorrhagic E. coli. Remember that these are not exactly the same. Enteroinvasive E. coli is not the same as EHEC. Enteroinvasive E. coli causes things like gastroenteritis. But EHEC, enterohemorrhagic E. coli, this has that Shigella-like toxin. It's O157H7 is the most common subtype, and it causes hemolytic uremic syndrome. So the Shiga toxin can cause hemolytic uremic syndrome, where you have microthrombi forming in the arterioles and the capillaries, and then these kind of build up in the kidney. They shred red blood cells. They destroy everything, and your body is in total chaos, right? So the induction of thrombosis with HUS is one of the findings for enterohemorrhagic, not enteroinvasive E. coli. They'll try to trip you up with that because they sound the same, so you're gonna pick them the same way. Next we have Campylobacter. Campylobacter is bloody, okay? Bloody. This is a polar flagellar organism. Campylobacter enteritis is seen in campers, and you gotta watch out for Guillain-Barré syndrome in these people. GBS, ascending paralysis. Monoarticular arthritis is another thing you can watch out for. Okay, Campylobacter. Then Salmonella. So non-typhoidal Salmonella can cause bloody diarrhea. This is, again, just like Campylobacter. It has a flagella. It's found in poultry, eggs, pets, and it's one of those conditions that, you can have kind of a rash association. So typhoidal, I believe, has the rash in Salmonella, and non-typhoidal has no rash. It just has this bloody diarrhea. Shigella toxin, right? Remember, Shiga-like toxin for our EHEC. Shiga, the original, the OG Shiga toxin comes from Shigella. And this is a pretty non-infectious bug, so it has a very low infectivity rate. You need to take in a ton of it to actually get the disease, but it causes dysentery, diarrhea, blood. Humans are the only host for Shigella, so you'll get Shigella from someone else if you got it at all. All right. Yersinia enterocolitica is found in pork and milk products. Again, bloody diarrhea. You can see it in kids in daycare with Yersinia enterocolitis. I think it's also transmitted through dogs as well. And then Entamoeba Histalitica. This is a fecal orally transmitted amoeba. You'll have things like amoebic cystitis, sorry, not amoebic cystitis. Amoebic cysts. These cysts can be excreted in the stool. They can also go to the liver and cause liver abscesses. So amoebic dysentery is associated with liver abscesses. So we've gone through kind of the viral causes, the bacterial causes of bloody and non-bloody diarrhea. What else should we talk about? So you can't rule out other causes of watery diarrhea. Like, for example, if the person is taking laxatives, or if this is kind of a self-induced diarrhea through laxative abuse. Fictitious diarrhea is one they like to throw out, where the person has a history of many hospital admissions. they have this chronic watery diarrhea. Colonoscopy can show things like melanosis coli. Remember senna? If they abuse senna, you can have melanosis coli. Senna is classically one of those anthraquinones. I think that's the drug class. Aloe vera can also cause melanosis coli if you eat it. So, fun fact there. Other things that can cause, are commonly used for laxative abuse are things like flax seed, lactulose, bisacodyl. What other things can be used? Even rhubarb, actually. If you eat enough rhubarb, you're going to poop your pants. Clinically, this is an osmotic, not a secretory diarrhea, if it's going to be self-induced, because a lot of these are just osmotic agents. You'll have hypokalemia. Remember, when you poop out a lot, you poop out a lot of your potassium. So just watch out for that. Melanosis coli, they like to give that to you because they say, and then you think, is this self-induced? Is this person abusing senna? Is this person eating a ton of aloe vera? I don't know. All right. So other than that, what else can we talk about? Stool osmotic gap, something that's commonly not really mentioned a lot, but it's a good test fodder. So if your stool osmotic gap is low, let's say less than 50 osms per kilogram, you have a secretory diarrhea. This is kind of from things like foodborne infections, endocrine tumors. VIPomas love to have secretory diarrheas with low osmotic gaps. Cholera does this. E-tech does this. Anything where you're kind of producing proteins and secreting them into the bowel to be excreted. And then high osmotic gap, which is greater than 100 millosms per kilogram. This kind of diarrhea is very common with laxatives, like we talked about. You'll also see this with celiac disease, Whipple's disease, and pancreatic insufficiency. So if the pancreas is producing too much hormone, like in a VIPoma, you'll have a low osmotic gap. And if the pancreas is producing not enough enzymes, you'll have a high osmotic gap diarrhea. Okay, so important that if this diarrhea goes on for too long, if it's chronic, if it's greater than, I think, 4 weeks, then you can consider doing something like a colonoscopy or a CT to rule out things like IBD and chronic infectious causes, to get biopsies and things like that. Okay. So now we've covered diarrhea, tick-borne illnesses, NMS, SSRI-induced conditions. Okay, what else can we talk about? I think I want to talk about bone tumors. Bone tumors, I feel, is a really great test fodder, especially in pediatrics, where you have things like osteomas, chondromas, osteoid osteomas, giant cell osteomas. What's the difference between an osteoclastoma and an osteofibrous dysplasia? So I think bone tumors is a really big topic. So we'll cover it in the next podcast. I hope this one has been helpful for you so far. I like to give a little forecast for the next topic in my current podcast. We kind of jump around through topics because I feel it's helpful. We can make little tiny associations sometimes, and it helps to keep our mind, fluid and limber. That's how the test is going to be. It's going to jump from topic to topic. You never know what to expect. So hopefully today's podcast was helpful for you. I know it was a good little review for me as well. And I'll see you guys in the next one.